Well, here we are with the HemOnc Pulse at the 11th Annual SOHO Meeting in beautiful Houston. Although, I mean, honestly, you guys could have a better weather than this. I mean, it's muggy and humid like crazy. We are going to spend some time talking about few elements of AML and MDS. And I hope to hear from you about your thoughts about other topics we'd like to cover. Rami, I want to start with you just by, I guess, separating myth from reality. Are we at a stage now where MDS is no longer a pre-leukemia? It's an own entity and disease.
Absolutely. First, thank you for having us. It's a pleasure to see you. And yes, I think MDS is an entity by itself. Obviously, still around 1/3 of the patients could transform to AML. I think AML could be an entity coming from MDS. But in reality, even if we look at what we label as a lower risk MDS, and you look at those patients, the disease does impact their survival. Around 50 or 60% of the mortality is directly attributed to MDS, and obviously the impact on quality of life. So definitely, I think we are moving to the other spectrum now, where we are talking about pre-MDS. So we talk about clinical cytopenia of unknown significance, clonal cytopenia of unknown significance, CHIP. So we are moving the spectrum to the other side. But again, there is definitely overlap. There is some biology that's the same in MDS AML, but I think it is a unique entity, and we cannot just think of MDS as a pre-cancerous condition. It is a true cancer, it's a problem, it affects the survival for patients.
For clinicians, when they're faced with an MDS, there have been recent classifications. I'll ask you, Dr.
Sure.
Daver, about this in a little bit, but with the recent classification came from WHO and ICC, anything affected MDS, how we look at MDS with the recent classification?
Yeah, absolutely. Obviously, first it created a lot of controversy. But I think the most important is really the recognition that we clearly have molecularly defined groups. So now, like deletion 5q we knew about for many years, we have lenalidomide for that. But now we have SF3B1 mutant, and obviously we do have some therapeutic implication with that with luspatercept. P53, particularly the biallelic, this is an entity unfortunately patients don't do well. This is a common theme between us and the AML. So clearly the recognition of molecular defined entities. And then I think when we come to the morphologically defined entities, that we are really finding that the line between MDS, AML is a little bit blurry. What's the percentage of blast cutoff to call MDS, AML? I personally think once you have a blast more than 5%, it's a different biology from the rest. And is it like, 10%, 20%, it's hard to tell. I think there are pros and cons for the classification, because now in the new classification, if you have more than 10% blast, you call that AML/MDS. And that can have pros because it allows us actually to get access to some of the drugs in AML. It can have some cons and even first creating anxiety for the patient, because I think still AML is thought of as more serious disease. And then some implications on clinical trials, which response criteria do we use? But I think there are advantages, and we should take advantage of that, merging those two areas together.
So, I mean, speaking of classifications, AML, to your point about the controversy with classifications, it's not easy to explain this in a simplified manner, but
Sure.
I'm going to ask you to do that, because a
Of
lot
course.
of our viewers may not be just seeing leukemia day in and day out.
Right.
So with these classifications, how do we simplify the way they approach leukemia patient in clinic?
Yeah, I think the biggest takeaway, without getting into the weeds from the classification, is that the blast percentage per se is not a critical decision-making factor. The molecular and cytogenetics, which makes sense, right? I mean, it's like science. As you progress and you can really get to the crux of the matter, which is the molecular cytogenetic, you don't need these artificial things that we had to use 30 years ago because we didn't know the molecular. So today, I think when you have a new patient above 5% blast, more than worrying about MDS, AML, I think what you need to know is what is the FLT3 status, what is the NPM1 status, IDH1, IDH2, TP53, and now MLL rearrangement, core binding factors. So this is really what is going to help decide what you need to practically do for treatment for a patient.
20% blasts?
For regulatory purposes, yes, it's still 20. The ICC now recognizes an entity called AML-MDS, which is 10 to 20% blast. And the WHO has even gone beyond and just said if you have certain mutations or cytogenetics, which includes NPM1, FLT3, MLL, core binding factor, we don't care what the blasts are, which I agree with. you have a molecular or cytogenetic driven disease that has a targeted therapy. So you should use the targeted therapy. So really what matters, and I think in 5 years, this will fully consolidate that all that matters is molecular cytogenetics. The blast percentage is not going to impact your treatment choice per se. Now I agree with Rami, they're below 5% in people who have really low blasts is a different group completely. This is hypoplastic population, aplastic anemia / MDS, and the treatment should be completely different. But once you get above 5, whether it's S7, 11 or 15, doesn't really change. What matters is what your molecular and cytogenetics are.
I mean, I see the point, and I agree with both of you that the molecular kind of makeup of the disease is way more important than arbitrary blast percentage,
Right.
because it obviously gives you the biology of the disease. But what I fear, and please correct me wrong if I'm wrong, what I fear is over-treatment. So for example, if I have a 7% blast counts, and even if the individual has a cytogenetic abnormality, maybe I don't need to treat if this is like an MDS study.
Absolutely, and your point is well taken. I think part where the classification evolved is also where the treatment is evolving. So I think both of us are not thinking of intensive chemotherapy, the classical 3+7.
Right.
We definitely don't want to give somebody with 7% blast 3+7.
Correct.
We are talking targeted therapies, moving goal. I think that will be molecularly driven at one point, probably regardless of the blast percentage. But you are absolutely right. If you have somebody have 7% blast, have adequate blood counts, not even thinking of a curative therapy like AML, transplant, there is really probably no need to treat those patients at all. Observing them is okay. And I think when we are talking about this, we are really talking more about the modern targeted therapies. We have like FLT3 inhibitors, we have IDH inhibitors. We are shying away from intensive chemo. So I think the blast will maybe remain sometimes arbitrary in deciding intensive chemotherapy if we are using that.
Yeah.
But eventually all that line will disappear. Actually, if you dip into the AML, as I mentioned, if you look at the AML patients, elderly, probably 50% or more of them by ontogeny are defined that they came from MDS, splicing mutations enriched, certain mutations that tell you that. On the other hand, there are things probably we are just catching earlier. An NPM1 is probably from the beginning almost a de novo AML
Yep.
that we just caught earlier a little bit.
Yeah.
But your point is very well taken, and by no means the message is 7% treat like AML.
Correct. And I think what we mean by treat by AML is completely changed, right? 3+7 is really kind of the option when we have no other good options. So 7%, if you take that example, I think that's a great example. So if that patient had an NPM1 or IDH1 or 2 or FLT3, I would treat them with a targeted therapy-based approach, whether it's HMA plus an IDH or HMA-VEN if they're NPM1. And if that patient had TP53, if I wanted to treat it, I may do HMA alone. And if they had a core binding factor, I may actually consider giving them intensive. So again, for that patient, really what will decide what treatment I do is going to be based on their molecular cyto. And I think that's how we're thinking about it,
One of the trials that you're a co-author on and amongst your colleagues is the COMMANDS trial, which looked at low-risk MDS. And I'd like you to explain what you mean by low risk in this trial, because I do think it's, explaining this to the clinicians to know when to use the newer therapies versus ESAs is important.
Right. So lower risk historically has been defined by any of the staging systems, International Prognostic System, revised IPSS, and now we have the IPSS-M. The idea when we say lower risk is basically transformation to AML and survival. So those patients have less likelihood. So on the trial itself, they used the revised IPSS, so you had to be intermediate or lower. You needed to have some blood transfusion, at least minimum 2 units of blood. And you needed to have endogenous serum EPO level less than 500 to be fair for the control arm, the EPO. I think obviously in lower risk MDS, what we lump as a lower risk MDS, historically the problem is transfusion dependency. Most of the time when we are treating anemia. Sometimes your concomitant thrombocytopenia or neutropenia will dictate your choice of therapy, but most of the time when we go in to treat anemia. We know for a fact transfusion dependency is bad. It correlates with worse outcome, worse survival, but worse quality of life. And so that's the goal of the treatment. Whether that transfusion dependency is just reflecting bad disease biology or complications of the transfusion itself, it doesn't matter. Once patients are transfusion dependent, that's bad. So we want them to become transfusion independent. Historically, ESA, erythroid stimulating agents, had been our mainstay for treatment. Roughly you get like non-selective 30 to 40% responses for a year and a half. If you start like selecting a little bit more, somebody that have high endogenous EPO, more transfusion burden, the chances of response are actually less. So the luspatercept was originally approved by the medalist study in patients after ESA failure with ring sideroblasts. In the commands, they moved earlier. They said, let's take patients.
Well, what class of drug is it?
Luspatercept is a TGF-beta, neutralizing protein or fusion trap protein. So it binds the ligands that activate through the TGF-beta pathway. And by that, it releases the terminal erythroid differentiation. So even the whole class is now called erythroid maturating agents. Erythroid stimulating agents work early on the erythroid precursors. This one releases the terminal block on the erythroid differentiation. So in that study, they took patients that needed some blood, lower risk by the revised IPSS, and randomized between ESA and luspatercept. And the primary endpoint was really becoming transfusion independent for a longer duration that we usually accept, which is 8. In this study, they went for 12 weeks transfusion independent, plus a 1.5 gram hemoglobin increase, which is a little bit really more robust or more objective response. And they showed that they doubled the response rates, almost 60% versus 30, and also doubling the duration. So I think definitely an improvement. I think when you start looking into the weeds of the study was enriched 60 to 70% by RS positive, SF3B1. There were a handful of RS negative. In the RS positive, it's very clear that difference, even more pronounced. In the RS negative, they were equivalent. So the question comes, do I use it in all comers or the RS negative or RS positive?
Right.
And I think you could look at it in both ways. I think it really comes sometimes to cost effectiveness. Those drugs are way more expensive than ESA. They are equivalent. There may be, in my mind, there may be patients that are RS negative will benefit from this. Like if the EPO level is high, even above 200, those patients don't do well with erythropoietin. If they have 2 or more mutations, they don't do well. So there could be a subset. But I probably in RS negative would like to see more evidence before I generalize this to be first line.
I have to say, from a cost perspective, you have to factor transfusion cost.
Yeah, that's true.
So transfusion independence could actually save cost.
Yeah.
Maybe my last question is, hearing you talk about all of these molecular subclassifications for AML, clearly it's not one disease.
Yep.
We've come much farther since the days of FAB and other classifications. How are you ready to incorporate MRD now that you know the actual clone? I mean, are you incorporating MRD in your decision making, whether it is de-intensifying therapy, whether going to transplant? How are you leveraging?
Yeah, that's a great question. And I mean, honestly, we're at the beginning of, I think, using MRD in AML. We're way behind ALL, CLL, but I think we're actually have the tools and the ability to do it. And I think the important thing in AML is just like the heterogeneity in the disease, the MRD monitoring and the implications, prognostic implications of each MRD marker are very different. So unlike ALL, where if you see any disease at any level by any assay, and the better your assay, the more predictive. In AML, that's not true. For example, NPM1 and FLT3 are very good, powerful prognostic MRD markers. You go from 10 raised to -4 to -6, and you're going to actually find a differential delta. But IDH1 and IDH2, and maybe even TP53, they're actually not good MRD markers. You may have them remaining or not, and actually studies have shown that they have no prognostic impact. So it makes it harder in AML, which is why I think it's taking longer, that we have to validate each marker as an independent MRD, valid or not, and I think we're getting there. NPM1, 3 studies have shown prospectively valid marker, very clear, high sensitivity assay, could be a regulatory endpoint. In fact, the FDA did consider regulatory endpoint on a study. Unfortunately, the study closed, but it was a 3+7 with a SYK inhibitor versus 3+7, and their primary endpoint was NPM1 MRD. So not only physicians, the FDA understands that certain markers, yes, FLT3, we're getting there. The study that Mark Levis showed, the Morpho study, we see that if you're MRD positive at any level, 10 raised to -6, then post-transplant gilteritinib dramatically improves relapse-free and overall survival. If you're MRD negative, then actually you don't need maintenance. So actually it is a condition where you may not want to give maintenance.
There were studies actually that showed intervention, because
Correct.
We know MRD positive is bad prognosis.
Correct.
Right.
But I'm glad you highlighted this, because one of the few trials where an intervention might make a difference based on the MRD.
Based on MRD, and also where you may not want to give the intervention to an MRD negative patient if you can get that assay. So I think that whole question that people ask, is maintenance in or out, is the wrong question. It is who should get maintenance and who should not. And I think MRD will help us know that. So I think we're actually having a lot of discussions with the FDA as well. Everybody's in this mindset right now. I think the next 3-4 years, a lot of prospective data and analyses are being planned, and I think this will really move the bar. And I do think we may see in the future, especially for NPM1 FLT3, that MRD becomes a regulatory endpoint and also decision-making endpoint as to, do you need a transplant, do you need a maintenance, do you need a maintenance post-transplant, and for some people maybe you can really stop after doing intensive chemo consolidation or give minimal maintenance. So I think it's great to have all the drugs, and now we have to get them approved earlier in combinations using MRD. So it's great.
I would say, like, to add,
Yeah.
today in the practice there are things we use. I think the message for the community doctors that, like, you know, core binding factor, NPM1, those are not anymore just research subject.
Yeah.
We, you know, change patients' treatment based on that. Somebody who's persistent positive, after that you're going to think of transplant. So those are actionable. Obviously people are used to APL.
Correct.
It's actionable. Now I think with the Morphus data, as Naval alluded, FLT3 positive really benefits from maintenance. I think we have some data even with oral azacitidine maintenance benefit that was more pronounced in the MRD positive. So those are not anymore just subject of research. Those are things applied in current practice for patient management.
Yeah.
Well,
Yeah.
folks,
That's good.
look, you've got 3 months to solve all of the issues of MDS and AML, because I'm going to see you at ASH in San Diego.
Done.
And we're going to do this again. Perfect. Thank you.
That's
Rami.
awesome. That's
Thank you,
awesome.
Naval.
Thank you. Thank you.
Yes.